Good evening, ladies and gentlemen. Warm greetings to each and every one of you joining this live webinar. A very interesting topic, a topic that we've been asked for since a lot of days, and something that has been doing around the clocks for all dental professionals, not just dentists, but all dental professionals, particularly dentists, because it's been a long time, and I'm sure each and every one of you is missing your dental practice. And sure enough, you would definitely miss your dental practice because that's where you get your satisfaction. But definitely in these unprecedented times, it's very difficult for us to start with our dental practice. And hence, we thought, why not come up with a topic which would help you to clear your confusions before you begin with your dental practice. So here's me, Ruben Lobo from DentistChannel.Online, welcoming each and every one of you for this live webinar. We're so very happy to have you as our dear participants. Thank you for joining us. Very quickly, since it's evening, I'd want you to tell us your names and the city where you reside in the chat box. You can type out your full names and the city where you reside in the chat box. We can do a quick introductory session before we start with the much awaited presentation. Come on, ladies and gentlemen, I want each and every one of you to quickly type your names and the city where you reside. Thank you. Thank you for joining us from various parts of India. I can see Chennai, Mumbai, Bangalore, Kolkata, Pune, Kerala, Goa. Wow. Some Saudi. Some people from Northern Africa as well, from Gurgaon, Andhra Pradesh. Thank you, ladies and gentlemen. Good evening to each and every one of you. Once again, it's a pleasure to have you for this webinar. And I'm sure by the end of the webinar, you'll have all your doubts cleared because we have a very special speaker, a person who's got the knowledge and a person who knows based on evidence approach. He's going to give you a presentation on a topic which will help you to clear your confusions and all your doubts related to post-COVID dentistry. It's my pleasure to welcome our speaker, Dr. Vinoo Mathew. Dr. Vinoo Mathew did his master's in Prosthodontics from Manipal Academy in the year 1998. He did his master's in implant dentistry from the Warwick University, UK in the year 2010. He's worked in Zaid Military Hospital for 6 years. He's been into private practice since the last 10 years. Currently, he serves as the director of Aspen Dental Polyclinic in U.A.E. He's presented seminars and lectures all across the globe. We're very lucky to have you, Dr. Vinoo. I request you to kindly start with your power pack session on a very important topic, post-COVID dentistry, clearing confusions for dental practitioners. Ladies and gentlemen, Dr. Vinoo, live.
Good evening, friends and colleagues. Am I audible?
Yes, sir. You're very audible. Yeah. Please proceed.
All right. Thank you. I can see a lot of people from different parts of India, especially, and also from the Middle East. So good evening to you all. First of all, I would like to take this opportunity to thank DentistChannel.Online channel, which has given me the opportunity to share this knowledge with you, which I have been, just like all of you, been in a confused state for the last 2-3 months, because our profession, which is dental practice, which is our bread and butter, but also our passion, has been affected by this latest development of the pandemic. So what I would like to concentrate today would be on to get some kind of footing for the dentist with a plethora of information out there, confusing, contradicting. Everyone is confused, scared, to the extent of some people are calling up, asking whether should we shut the practices, should we open the practices. There are a lot of confusions all around the world. I've been following this for the last 3 months, and maybe due to my own passion, I followed up with each and every paper that has come out of it, each and every webinar, each and every YouTube channels. And I would like to summarize a little bit of my information to you to make everything into a perspective for your own practice. So let's start. See, the rapid emergence of COVID-19 has created a tremendous uncertainty in medicine and dentistry. and we don't know where this pandemic is headed. We don't know the ideal management strategy either. Every day brings conflicting information. But knowledge has been an important pillar of our sense of control in medicine and dentistry. But with COVID-19, we have found the highlighting of a massive gap in this knowledge. One of those gaps is in the precise mechanisms through which infectious diseases spread and how best to protect ourselves. We hear the terms like aerosol generating, droplets, but the precise meaning can be unclear. And so it is hard to know how to go about facing this unknown enemy into your own small dental practice room. So I would like to make this into three ways. One is, let's look at the parties involved. We are dental fraternity, and we have the public, that is our patients are coming from. And then comes the health authorities and the governing bodies. So let's see what the public is seeing. The public is actually getting a lot of information from around the world through many news channels with this advent of social media and innumerable information which may be right, may be wrong. Basically, they are scared. When it comes to the dentists, most of them are equally scared too, but at the same time, they are looking at a stark, very bad future. If
Dr.
they don't open up their practices, it becomes difficult for them.
Dr. Vinoo, sorry to interrupt.
Yeah.
You need to your screen share.
Okay.
Yeah.
Please.
The screen share option.
All right. Is it good?
It's good, sir. Please proceed.
Yeah.
Thank you.
So for dentists themselves, it was a time when they are contemplating what to do. If they open the practices, will I be safe? If I don't open, will I lose out my patients? Will I be looking at a very bad future? So let's look at what the authorities are doing. So that itself is quite confusing. If you see the authorities' response from the Western Hemisphere to the Middle East to India, it looks different. In the Western Hemisphere, especially in America and in India, the authorities are told to shut down practices in the beginning, while in the Middle East, we were advised to do only emergency procedures, while in places like Sweden and Europe, they were doing routine dentistry. So again, there is confusion and there is no unanimous decisions. So what makes this thing so confused? I have to start with a major caveat. The reason is the enemy itself is highly tricky and confusing. So let's start with the different schools of thought what we have from our, wait a minute, yeah, something, yes, it's more moving, yeah. All right, so let's see, it is COVID-19 is the infection, SARS-CoV-2 is the pathogen, size is around 0.06 micrometers to 0.130, route of transmission, mainly droplet, contact, and aerosol under questionable presumption. So what is an aerosol? In general, aerosols are liquids or solid particles suspended in the air. They can be visible like a fog or can most often invisible like dust or pollen. Droplets are exhaled when we breathe, speak, and cough or sneeze. Large droplets drop to the ground before they evaporate, causing local contamination, while the disease transmission through these last droplets is what we often refer to as droplets or contact spread. While the droplet sizes, which is normally larger than 5 microns, and when these droplet sizes become smaller than 5 microns, we call it a droplet nuclei or an aerosol. And the aerosols are so small that the buoyant forces cause them to oppose the gravity and allow them to stay suspended in the air for long periods, or they evaporate before they hit the floor, leaving the solid particulate called droplet nuclei free to float very long distances, causing what we often refer to as airborne transmission. You people might be thinking I'm going on a big lecture. No, it is not. This is very important to know because this is the crunch of our confusion. So we should know the difference between a droplet and an airborne transmission. So what are aerosol generating procedures actually? An aerosol generating procedure in medicine is that creates an aerosol in addition to that naturally a patient creates, like during breathing, coughing, sneezing, or talking. So what are the normal aerosol generating procedure which we know of in medicine? We know many, but look at the last two, the nitrous oxide sedation and dental procedures. Dental procedures, I put it in question mark because there is an argument that it is not a bioaerosol and dental aerosols are different. We will get to that later. So what is this dental aerosol generating procedures? As you all know, and you are aware of all these procedures, it stops with the ultrasonics and any air turbines, use of air water syringe, surgical motor, you name it. So what can we procedure? When somebody asks me what all emergency procedure that you do, I would just laugh at them because we actually cannot do anything without any of this. That is a stark reality. So let's get into it. First school of thought. The first school of thought is from the authorities. This is from the Center for Disease Control in America, Occupational Safety and Health Authority from OSHA from states, and also from different authorities, including your own respective dental councils and dental regulatory bodies. What they say is that COVID-19 is primarily a droplet infection, but can be an opportunistic airborne transmission over a limited distance. And dental droplets, splatter and aerosols can be a potential route of transmission, and you need very high PPE or high protection mechanism for resisting this, and which resulted in initial closure of dental offices or emergency care only. What were the pros of that? Dental offices and the DHCP were not reported to have any large-scale outbreak or infection, while the cons was denial of the dental care, which is a primary essential care for the public. And there is a huge revenue loss for dental practices due to this. Second school of thought came back from Germany with Dr. Marcus and Dr. Shikhon, then Eduardo Mann, and also recently from Dr. Shankaraya, who is a teacher to me and I respect him a lot, from the States also. So what are their actually school of thought? What they say is that COVID is a droplet infection and no airborne or aerosol transmission. And one of them argues that it's a bioaerosol is different from the dental aerosols we create. And surgical mask, I put it in inverted commas and I'll explain to you why. And existing sterilization protocols are sufficient and no need of any additional settings like an HEPA room filter. So what are the pros? Dental offices can be opened and resumption of routine dentistry, which is very good. Overheads on PPE, especially to the practice owners, can be minimized, reducing the overall economic burden. While the cons are non-regulated PPE and the practices can be a counterproductive problem, and also risk of dental offices becoming a breeding ground for COVID infection. So let's look at the first one. That is the first school of thought represented by the regulatory authorities, which is mainly represented by CDC. What do CDC say? CDC actually tells you the fact that aerosol generating procedures, whenever you're performing, you need a higher level respirators like N95 or above. And they say if a respirator is not available, you can use a surgical mask with a full face shield. And also they say that there is no clear evidence to support the use of this. In the transmission, they come to the conclusion that it is a droplet infection primarily, but we are still learning and it can be spread through airborne transmission. So the risk, when you assess the risk, what they meant is here, you can go into that and they say there are no, the words exactly is like this. The surgical mask protect mucous membranes of the mouth and the nose from droplet splatter, but they do not provide complete protection against inhalation of airborne infectious agents. And there are currently no data available to assess the risk of SARS-CoV-2 transmission during dental practice. Let's look at what is OSHA saying. So according to OSHA, they classified them into well patients and patients with suspected or confirmed COVID-19. That itself is very confusing because we know very well that enough and more data has come out of the fact that asymptomatic carrier state is a real and evident phenomenon. And we do have COVID-19 present as an asymptomatic carriage, and it can be an infectious carrier. So whatever the reason is, they have put forward both kinds, but again, they are mentioning almost same categories like CDC is telling, but they go into the use of higher respirators and even a PAPR or a PAPR, powered air purifiers, for a suspected COVID-19 patient. So let's see what CDC's preferred and acceptable alternate PPEs available to us. The first one they say is you need a isolation gown, you need a respirator, preferably N95 or higher, a face shield or goggles are a must, but they are not insisting on a head cover or a shoe cover here. While in the alternate PPE route or acceptable one, when you don't have the ability to procure an N95 mask, they say a face mask which is of level 3. So let's see the other argument which is coming from the other school of thought. That one is the bioaerosols versus dental aerosols. And bioaerosols are originally from respiratory ciliated columnar epithelium, and it comes from a cough or a sneeze, while dental aerosols are mostly salivary origin, also diluted by the cooling liquids of rotary instruments. And hence, this word is very important, the viral inoculation from a dental aerosol volume is not sufficient to cause a COVID-19 infection. So this part we will analyze. So let's see what they are, what evidence they are coming up with. They have a lot of evidence to support what they are saying. I cannot go through all the data, but I will just show you the different kinds of journals which we can support from them. One thing is the age-old concept of cross-transmission in the dental office. Does this really make you ill? You know, that is the risk of transmission of pathogen in dental office resulting in an infection disease is still unknown. That means it is not at all dangerous. But then comes the healthcare associated viral and bacterial infection in dentistry. And this study, which is the one which clearly says that the virus inoculum is not good enough in a dental practice to cause an infection. But this study was entirely an influenza A study conducted in mice. And also coming back to the second argument they made is that the COVID-19 infection is entirely a droplet infection and it is not by aerosols. And the droplets normally gravitate and fall down and don't travel long distances and don't remain, very important words, remain viably infectious in the air. As you know, what is more important is this sentence, that if the droplets and splatter, we can take care. But if aerosols are there in the air and it is going to remain viable in the air, then our protocols changes entirely. I will come to that later. So COVID-19 outbreak, especially they are mentioning the study, which was in that, you must have heard of this study called in an air conditioning restaurant in Wuhan, in China. First, they thought that it is an airborne, but they found that it was completely by a droplet transmission. Then there is a study of the modes of transmission by World Health Organization, giving more preference towards the droplet infection. Third argument is about the face mask or the surgical mask are only needed and we don't need anything else other than them. And we do have enough infection control procedures in dentistry, robust ones to be in fact present already. We don't need any more actually to counter this. Let's see whether if this is what they have come up with for this. We have very good studies for this, to be frank, because when you compare N95 and surgical mask, we have a plethora of studies which say that there is no statistical evidence to prove that N95 is better. Here you can see that although N95 respirators appear to have a protective advantage over surgical mask in laboratory settings, our meta-analysis showed that there were insufficient data to determine definitely whether N95 respirators are superior to surgical masks in protecting healthcare workers. So all the effectiveness they found only in a laboratory study, not clinically. And here again, they say that because of the paucity of the high quality studies in the healthcare setting, the advocacy of mask types is not entirely evidence-based. So the contentious question here is, does dental aerosols has COVID-2 virus? It all boils down to that. And let's see what they said is correct or not. Let's take the first one, that is the bioaerosols and dental aerosols. They said it is different. But as we know here, there is a lot of studies come up to say that the COVID-2 virus is highly loaded in saliva, to the extent that after nasopharynx, saliva has the highest rate of COVID-2 virus presence, or the colony. And the viral load in saliva, this is very important study. It is done in Korea. I will come to that later. This is the latest study. They said that the viral load in the saliva decreased transiently for 2 hours after using chlorhexidine mouthwash. This is the latest study about, okay? Because till now we were talking about only povidone iodine and hydrogen peroxide. Anyway, so what they meant is there is definitely a higher load in saliva, and they were looking at saliva as a reliable tool to detect SARS-CoV-2, because taking a nasopharyngeal swab is not a very pleasant experience if any one of you have gone through that. So saliva would be a much more friendly medium to do the testing. And FDA actually authorized to do this sometime back on May 8th itself. And there are studies to say that whether saliva is a friend or a foe. Friend because it can be used as a diagnostic tool, foe because it will put us into a very different scenario for transmission. There are many studies to prove that. So the first argument that the bioaerosol and dental aerosols are different doesn't stand very big ground. Next comes that whether the viral inoculation volumes in dental aerosols are not sufficient to cause a COVID-19 infection. Let's look into that. Let's look at the microbial aerosols in general dental practice. And here it's very important. You can see a risk assessment was carried out by calculating the airborne quantity in the aerosolized saliva. And what they found is that the dentists and the dental assistants are exposed to a peak aerosol pathogens for a period of 15 minutes in this study. And also in the basic arm of studies which we have for dental bioaerosols from long time, they clearly say that all procedures performed with the use of dental unit hand visors cause the formation of aerosol and splatter. And also here, one thing I have found very interesting is that the highest microbiological contamination due to aerosol and splatter are in doctors and assistants' masks. So there is definitely higher volume of pathogen in dental aerosol, but we don't know how good enough that is to cause especially a viral infection like COVID. Again, they have this aerosol and splatter study for ultrasonic scaling, in which very clearly they have found that there is an increased prevalence of respiratory infection among dentists in the symptoms which are related to the highly contaminated breathing zone in the dental operatories. Aerosols remain in the air for a long time, even after the completion of the dental procedure, and have the potential risk of entering the respiratory passages. So that argument is really contentious because we still don't know, okay, how much viral inoculation is required for a COVID infection is questionable. So that argument is quite valid. So coming to the next one is that COVID-19 infection is entirely a droplet infection and it is not by aerosols. This one, let's look at it. There are immense studies coming up with the droplets and aerosols in the transmission of SARS-CoV-2, that here we're clearly saying breathing and talking also produce smaller and much more numerous particles known as aerosols, and that visualized in the laser experiment. This is the laser experiment which came out in the social media a lot, which is by Mr. Ani Finrud. He did that study. And also, and the airborne lifetime of small speech droplets. This study also did with the laser, and they found that the aerosols are floating around in the rooms for a larger period of time. In this perio implant advisory, again, they say in the third and most significantly, this new virus strain has been shown to be much more efficient at traveling more considerable distances and becoming aerosolized. And they did a pictogram on it and will say clearly up to 20 feet. So there are many more studies, but here it comes the main crunch of the thing. Although we have not established the infectivity of the virus detected in these hospital areas, we propose that SARS-CoV-2 may have the potential to be transmitted through aerosols. So it has the potential. Again, study after study from Wuhan, there are hospital corridors, air being tested, found to have aerosols. We don't know exactly, is it come from the patient or is it being transmitted through any other way? We don't know, but there has been evidence of COVID-2 present in aerosols. There is again study about this from Wuhan again. So that argument is not very contentious because we do have feeling, especially from CDC, that it can be an opportunistic airborne infection. Third argument is that the face mask or surgical mask are enough than N95. Out of all these arguments, this is the one which I personally found quite contentious, and it is quite good because this is something that we could do. But there is a caveat here. Surgical masks are actually good, but what is the caveat? What kind of face mask? Nobody tells about it. There are hundreds of face masks available around the world. And if you see the surgical mask standards, there are European standard, which takes into 3 levels of filtration, which is BF-E1, E2, and Type R. And American one, which is an ASTM standards. This also has 3 levels of protection. And here you can see that in Europe, surgical mask must wear a CE mark complying with the requirement of EN 14683. And in the States, it's a surgical mask with ASTM levels of level 3. So when they talk from states that surgical masks are enough, they are talking about level 3 mask. And how many of you in different parts of the world, in India, and also in Middle East and Africa, have access to this? The mask what we get from your local dealer, how do you know that they are this quality surgical mask? We don't know. And let's look at this Journal of Textiles and Apparel study. They did on many kinds of, these are very good masks. They did different studies on 6 standards of mask, and they found different filtration efficiencies in them. So what is the efficiency in this study? They say, what is the efficacy of standard face mask compared to respirator mask in preventing COVID type respiratory illness in primary care staff? And they found most real world research comparing the standard face mask with respirator mask have been in the context of influenza or any other relatively benign respiratory conditions and which are based in hospitals. There are no published head-to-head trials of these interventions in severe acute respiratory syndrome or COVID-2, SARS-CoV-2. So what is the truth? Let's see. The fact is, there is a lot of argument here and there, and we know that we want to open our practices. Yes, closing down practices are not the solution. We have to continue doing our work, but we have to make sure that we have to be responsible and we take adequate protection. Why? Because we don't know the truth still. There are no evidence-based studies on SARS-CoV-2 virus or COVID-19 infection on a clinical dental setting till now. We cannot compare previous studies based on a different virus or a different pathogen applied to COVID, since COVID has behaved completely differently than any other pathogen before, and its contagious potential is reflecting to be more than its cousin SARS-1. World has not seen a pandemic of this scale in our living memory. And here they say there is a limits of evidence for procedures and the infective risk regarding SARS-CoV-2. Where we do not have evidence relating to SARS-CoV-2, guidelines for safety conducting these procedures should consider what risk procedures would have in transmitting related pathogens. That means we need to take adequate protection. And the British Endodontic Society is calling for a research to find whether there are problems in dental offices. So when we don't know fully, it is better to be safe. This is always the age-old theory. That is called as the precautionary principle. That is the responsible stand we dentists should take. Let's look at this, why it is. This is how a COVID-2 virus affects you and a COVID-19 infection establishes. You can see from the day 0 to day 5, it is asymptomatic. And on day 7 onwards only, an IgM becomes positive, and only from 14 it becomes IgG becomes positive. And all this while till day 28, it is infective. There is contention about 14 to 28 whether it is infective, but the fallacy of with the serological testing, that's what I want to tell you with this particular slide. A lot of dentists were proposing we should have the dental officers should be allowed to do the SARS-CoV-2 testing so that we can test the patients and we can be sure that they are not positive and we can start practice. That is complete nonsense, because we cannot know with a serological test only on day 7 that IgM becomes positive. Till then, it is asymptomatic and they are still infectious. And only a PCR test, which will give us from day 0 till day 28, whether a patient who is walking to your practice is having COVID-19 infectious state or not. So I don't think a serological test is going to solve your problems. So what should we do? I am a big advocate of getting rid of fear psychosis. You have to open up your practices, but be responsible and take adequate protection to make yourself safe, your staff safe, your patients, and also your family. Steps to do that has to be in a practical, economical, and most easy way. Because if you are going to look at changing your entire practice into something that is which is not affordable or something that is not practical, it is not going to work for us. So try to make it something in the middle to make it as safe as possible. There are some investments and costs associated with it. There is no way of going cheap. At the same time, use practical, easy, and economical solutions which are available, and don't go ballistic and overboard on it. Let's look at the 4 points which I have come up to approach this problem. One is the immunity improvement. As you all know that the susceptibility of COVID infection is a balancing act between your immunity quotient and the viral load you are exposed to. So if you are good in your immune quotient, you can be safe. Also, you can do some things on a daily practice to improve your immunity. I'm not going into it because this is a medical topic and all of you are medical professionals and you are aware of it. Next comes the screening part. This is also a little tricky because different kinds of practices exist in different parts of the world. In a Western kind of a practice, it is completely appointment based, and even in U.A.E, it is to a certain extent appointment based, where we can call up the patient, do a questionnaire, we can screen the patient and give them appointments on according to that screening. But there are many practices in India which does on a walk-in patient basis. In those situations, it is completely difficult to do a phone kind of a screening to be done before the appointment. But what we can do is to do some kind of on-site screening. So let's get into that. You can have some kind of questionnaire which gives you some indication towards the risk factor a patient gives us, okay? This is completely subjective, but I'm just going to put it out there. So there are questionnaires which we developed, which you can get it from anywhere. I can give this to you, any one of you also, which we go through it and come to some kind of a conclusion on the risk level at which each patient is. And also in our practice, we do have a consent for all those things what they say, so that we are not legally bound by anything. So according to CDC, how our practices should be. The practices should be having less patients. Patients should come alone, no visitors. Staff should adhere to the respiratory hygiene and cough etiquette. Chairs in the waiting room should be at least 6 feet apart. You know, we were proud of keeping our dental office receptions with these magazines, artifacts, you know, toys. I don't think that is possible now. We need to have a very clean, uncluttered environment for easy disinfection of the rooms. Minimize the number of persons waiting. This is something it's very difficult to do in some practices, but we can adapt some kind of social distancing. Then, of course, I'm going to just show you a small video where I am doing it how it should be, at least 6 feet apart. Please try to make this a PPE station for the patient when they come in, so that they will sit there and they will be given all the PPE required. Even the reception should be completely protected with some disposable plastic sheets. And if the chairs are close together, put a barrier there, insisting the social distancing. So once the patient enters the clinic, as the patient enters the clinic staff will record the temperature using an infrared thermometer and will guide them to the PPE station. At first, they'll be asked to sanitize their hands and a hand glove will be given. Subsequently, a head cover, and also after disinfecting their footwear, they will be provided with a shoe cover. Here I want to tell you something. The shoe cover and the head cover is not a mandatory thing for CDC or in any other guidelines, but I will tell you why we need to do that later, because there is a third component called public perception. Sorry. As the patient enters the clinic, using a invitation. At first, subsequently a head cover, and also after disinfecting their footwear, they'll be provided with a shoe cover. Patients are instructed to wear all these PPE as long as they are in the clinic. Once they leave the clinic, all these PPEs can be discarded and put inside the medical waste bin which is provided. So after each patient is done, patient PPE station will be disinfected by fogging and wiping using sodium hypochlorite solution after each patient. So what is the next step? Once the screening is done, the patient is not very risk category, and when we do the proper PPE for the patient, then goes into the advanced PPE option. This is an optional one. As I said, a good surgical mask, and if your practice is having a proper gowns and the face shields, all these are already there. The advanced PPE is optional. But for those people who think it is safer to do so, I want to give you the information for them. According to the CDC, they say that if the procedure likely to generate splashes, we need to have eye protection and a surgical mask. But for aerosol generating procedure, they are asking for an N95 or a higher level respirators. So here I will just give you a small idea about the mask and the respirators what we have. Since SARS-CoV-2 virus is a respiratory pathogen, I would like to go a little bit detail into the masks and the respirators available for us. Before I go into this, I want to make one point very clear, that any information I share with you are not in any way part of any guidelines by the health authorities or any governing body. These are my own personal interest, into which I went to gather information from around the world, and also based on the guidelines by CDC and OSHA's latest updates. Okay, coming back to the virus. SARS-CoV-2 virus is known to be 0.06 microns to 0.130 microns inside. Now, none of the filtration systems in the world available to us at the moment can filter that. But fortunately, the virus doesn't transmit by itself. It needs the medium. And normally, the medium we have is aerosol, droplets, or splatter. The size of a minimum aerosol particle is around 0.3 microns. And fortunately, we do have something called as the filters, or HEPA filters, HEPA 13 and 14 precisely, which will be able to filter 0.3 micron sizes. So let's see what are the available masks we have. First of all, what we have is a surgical mask we are all familiar with, which is a 3-ply mask with a filter inside, which will be worn through the air loops, and this will be quite good enough for doing any non-aerosol generating procedures. Is absolutely fine. Next comes the next level of it, which are the N95 masks and the respirators. If you're going to do an aerosol generating procedure, then the CDC guidelines advise us to use a N95 mask onwards. it's an advice. If you don't, it's difficult to procure these days, but if you can get one, it would be advisable to do that. So out of this mask, we have the normal N95 mask, which is the NIOSH certified one. The NIOSH certified N95 mask means it is certified by the National Institute of Occupational Health and Safety. And there is something called as the KN95 mask, which is from China, which is also equally good, but it doesn't get certification from NIOSH. What it does is both these masks filters particulate matter up to 95%. Why when you're going to look into the other two masks, which we have with the respirators, which uses what we call as a filtering mechanism. So these filters are put on either side of the mask, and there are different kinds of filters available. One good advantage about the mask, they are reusable and the filters can be changed. There is a little bit confusion regarding these names because it's N95 or that is an American specification. And we do have something called as FFP2 is a European specification. Either of these masks will do. There is one more category in this, which is the N99 or they call sometimes N100 and FFP3. Those masks will filter up to 99% of the particulate matter. But coming to this mask, here I would like to say something that the most important point here is the particulate matter filtration. So the aerosols are particulate matter in the particulate matter, and these filters are filtering. So these two kinds of masks are two kinds. One is N95 mask has a layered kind of filtration where the different layers in the mask is filtering the particulate. While in the elastomeric respirators, what it does is it has the respirator, the filters attached to the sides, and it is going to filter the through the filters and not a layering mechanism. So in an N95, the exhalation air is also filtered through back into through the layers, while in these respirators, there is an exhalation valve for it. So it makes the respirators much more comfortable. But I will come to the point of exhalation mask later. Since SARS-CoV-2 virus is a respiratory pathogen. Oh, sorry, it went to the... This is a long haul it's going to be. And N95 masks are something which is quite expensive and also cannot be reused. So we have a better option with these respirators because they can be reused. So in a clinic setup for the doctors and the nurses, to use a respirator would be much better than going with an N95 mask. So these respirators comes with two kinds of filters. One is the P100 organic filter. It is a very good filter, but the only problem is we cannot touch the side of the filter, and the filter has to be changed at least in 2 weeks' time. While the other filter is something called as a 7093C NIOSH approved HEPA filter, and these filters are concealed. It's very good to use. There is no problem in touching the surface, and also this lasts for almost 6 months. One more. Yeah, here I want to tell you something. There are different kinds of filters, concealed filters. One is the HEPA 7093. And also N95 filters are also coming in concealed type now. Sorry. These filters are concealed. It's very good to use. There is no problem in touching the surface. And also, this lasts for almost 6 months. One more point here to notice is that all N95 masks have to be fit checked. When you're wearing it, there are two kinds of strings. One, it goes back to the head, and this goes into the ear. Both has to be fit checked well to use. While these masks have an advantage that it can be fitted using these strings wherever it is available, where you can tighten them, and these margins are silicone, so it's very comfortable to wear, and it gives you a very tight fit. So the advantages for the respirators are, first of all, they are reusable. They are more safer because the filtration is around 99.97. And these filters have to be changed only in case of HEPA filter 6 months. So it is more economical. And also, because they are having the silicone borders, it is much more comfortable. So the PP advice for non-aerosol procedures are actually surgical mask, isolation gown, head cover and shoe cover optional, while visor is very important. As I said, it is a droplet infection. We need to have a face shield or a visor, and latex or nitrile gloves, while PP advice for an aerosol generating procedures are surgical mask, which is quite CE marked or ASTM level 3 mask, or N95 or higher, gown, head cover, shoe cover again optional, while face shield and surgical gloves are a must. So let's see here. You can see I'm just showing you how we can do a non-aerosol generating procedure. We can have the optional shoe cover, everything, but this will be a good shield, a surgical mask, and gloves will suffice for the assistance. While if you're doing a aerosol generating procedure, it is better to have the respirator and your shield. Head cover and the shoe cover are optional. If you have, you can use them. So if you see this, you can see very clearly in this, actually only the respirators are, you will think that it's very expensive. Rest of the things are not, because surgical gowns, if it is of good quality, can be autoclaved and reused. And all the other gloves, everything you're using before itself. The shield, most of the people are using, if not, it is not very expensive. While the respirators, and I will come to that later, even the elastomeric respirators are not very expensive like N95, and it is more comfortable too. So conventionally, what CDC said was, if you don't have N95 respirators, you can use any one of these. And out of this, you can see the third and the fourth, second and the third are powered air purifying respirators and elastomeric respirators. Actually, these elastomeric respirators are not meant for medical use. It was meant for an industrial use. But due to the shortage of N95, the CDC already approved to use them. But there is a caveat. There is something called as an exhalation valve for them, because this doesn't work by the principle of layered filtration. It works by the principle of filter-based filtration, and the exhaled air goes through the exhalation valve down. So this can be a problem to in some situations, like if you are COVID-19 positive or asymptomatic, you can infect somebody else. So what we can do for that, I will show you exactly. And powered air purifier is one of the best, but it is very expensive. I'm not going into it in detail, but here I can show you how an elastomeric respirator can be made safer by putting a surgical mask at the exhalation valve exit. This is very reusable, comfortable, cheaper, and safe. So the PAPRs or PAPR is only for interest sake. I'm not going into it. Now I would like to, it is already time is gone, so I'm not going into it. So let's get into the last point, that is the aerosol limiting protocols, which is again an optional one, but we should be looking into it because it can be an airborne infection. What you can do. See, when I went through this literature, I found one thing, that COVID-19 is just a recent infection, but we already had a lot of infections before, like most importantly, tuberculosis. It is a very airborne infection. So why not we did ever think about using any of these things while you're practicing? Because aerosol, tuberculosis, mycobacterium definitely is an airborne infection. So we have to be giving more importance to our infection control, and maybe COVID-19 has given us an opportunity to do so. So here, aerosol protection is done in many layers. We call it a layered protection, multifactorial. You can do many things or choose one or two to circumvent and do each other. Like first one is you wear a mask, then you can have a preoperative rinse, then high vacuum evacuation, and sometimes an HEPA filter depending upon your treatment room. So let's look at the first one. That is the rinse with 1% hydrogen peroxide or 0.2% povidone. And now there is a latest study saying chlorhexidine also. So there is a lot of studies with the H1N1 with the use of essential oil containing mouth rinses, and also with COVID-2 infection. There is one study which they done with they compared hydrogen peroxide, they compared povidone, but all these studies are not conclusive at the moment. Only this is the latest study from Korea, which they said that chlorhexidine mouthwash for 2 hours will definitely reduce the viral colony. And here it again, the research has been announced for immediate study for into this spectrum. We need to find out because we have to find solutions. Second one is using a rubber dam or an isolate kind of isolation system. A rubber dam is a very good option with high vacuum evacuation, but in many practices they don't do rubber dam, and in some procedures it is limited use. Isolate also is quite an expensive one. But one thing you can adapt will be a high vacuum evacuation. And when you do high vacuum evacuation, it's very important to know that we need to have enough power for it. I will get into that. Evaluation of splatter reduction effectiveness on 2 dry field isolation techniques, and they found that the study results showed that the use of dental dam with HVE or the isolate system significantly reduced the splatter overall compared with the use of HEV alone. So rubber dam and isolate are definitely good useful tools. In aerosol and splatter in dentistry, a brief review, they found that the usual HVE used in dentistry has a large opening, usually 8 millimeter is required, and should be attached to an evacuation system that will remove large volume of air up to 100 cubic feet of air per minute. This is the basic requirement for a high vacuum evacuation. You can put it into a practice purpose. What I found is if you take 1 liter of water and if you try to do it with a high vacuum suction, it should suck it out in almost 50 seconds to 1 minute, max. That will show you that is the high vacuum is quite good. Third one is an extraoral suction device, which is an optional one. If you don't have a proper rubber dam or a high vacuum evacuation, then you can look into this. There are many things in the market, but one thing what is very particular about when you're using it is to know that there has to be a HEPA 13 filter or a UV filter to filter the particles which are being aerosols which are being sucked in. The fourth one is a medical grade HEPA 13 or a 14 room air changer, which is again an optional one. But I would say the fourth and the fifth are all interchangeable. I will put it across like this. If your dental operatory has a outside window, you don't need any HEPA grade filter or any fumigation or fogging. What you need is to open the window, and if you can put some fan towards it, get a cross ventilation with the air taking the aerosol towards the open spaces. If you don't have and you have a closed room, you need a medical HEPA grade filter. Now, what is this HEPA 13 and 14 filter, which should have a medical grade air changer? That means it should have a 5 to 7 times of air change per hour. The normal room air purifiers will not work. They don't have that much of air changing quality. We need to have devices which has. So according to the CDC, they already said consider using the portable HEPA air filtration unit, and also a UV unit is also something that is advisable. What is HEPA? It is around 99.97 filtration and 0.3 microns it will filter. So ultraviolet also is germicidal and it is proved to be useful, but still no studies regarding these two. So what are the HEPA filters which gives that medical air change up to 5 to 7? There are 3 of them I found in the market, which is quite good, which is one is Blue Air, which has models like Classic, Sense and Pro, and also IQ Air, which is one of the leaders, which is called as an Health Pro, and they also have a dental vac, which one can be attached to this. Then there is something called a Surgical Clean Air, which is got a model called Cascade White or Jade. These 3 are the models which are quite good enough to do a proper HEPA filtration with a medical grade air changing. There are some studies regarding this, but not very effective. But there is definitely proof that viruses can be captured by the HEPA filters, and this is not a myth. Here they say that bottom line is that the HEPA filters will work well on viruses, and the myth of that the viruses are too small to be captured by HEPA filters needs to be eradicated. The last one is whether to do a fogging. I told you the ventilation option, fogging. Fogging can be done as an end of the day procedure where we can do with any of the solutions like hydrogen peroxide, hypochlorite, or even they say it can be done with any disinfecting solutions. The main purpose of this is to, I will show you how it has been done. So what it does is it atomizes the particles, I mean the liquid, into very atomic form, and this will go and collide with the aerosol particles, makes them heavy, and it falls down. So always after doing the fogging, you need to wipe and floor especially, and also all the surfaces, wipe and clean quite well. So coming to the patient volume strategy, the CDC guidelines tells us that at least minimum 15 minutes should be given for the aerosol settling using any of the procedures as he mentioned, like ventilation, fogging, or HEPA filtration. Whatever method you use to reduce the aerosols in a room before you see the next patient should be a minimum of 15 minutes. I'm just going to show you an ideal scenario, which you don't need to be replicated, but just want for information's sake.
Demonstrate the use of multiple protocols in an actual clinical scenario to reduce the aerosol generation in the room. Excellent use of four-handed dentistry with retraction, isolation, and high vacuum suction, and the additional extraoral suction to reduce the aerosols, droplets, and splatter. We already have robust infection control procedures in the dental clinics. The dentist and the dental assistant are donning the advanced PPE for the protection against the COVID-19 infection. The room air is filtered and changed 5 to 7 times using an HEPA 13 blue air changer. Also, after the procedure, the clinical room the windows can be opened and to allow for a cross ventilation. Room fogging after the procedure is an additional protocol which can reduce the room contamination. The surfaces should be properly put with barrier membranes, especially the computer keyboards and the mouse. If you're using any kind of equipment or machinery, should be properly protected. And this is the HEPA 13 filter from Blue Air, which is going to change the air 5 to 6 times per hour. And all the surfaces on the machinery are covered with barrier membrane, including the X-ray tube.
I would like to show you a picture which appeared in the our Gulf News here the other day, how the dentists are going back to practice. I was just astonished to see that. See, this is the point I want to tell you, that the third part of it, that is the public perception, okay? The public wants to feel safe. Even though there is no requirement for maybe a shoe cover, maybe there is no requirement for a head cover, but public feels safer if you do so. Just look at the next slide. Here we see an air hostess standing like that. And do you think a dentist can go like this to the patients now? How does it make sense? We are supposed to be a medical fraternity. We are supposed to take responsibility. We are supposed to take more care. The public perception has to be valued here. So personally, I feel we need to take protection, as well as we need to show we do that. Otherwise, people will be scared to come to our practices. Thank you and stay safe.
Thank you, Dr. Vinoo. Thank you for the lovely presentation. I'd like to request you to stop your screen share for a moment. Well, friends, I'm sure you've learned a lot from the session. And if you have, then I want you to mention it on the chat box as to what you felt about today's presentation. If you felt that the session was really wonderful, that you learned something, whatever it might be, I want you to mention it in the chat box. We would love and appreciate all your comments. Please do post your comments and we would love to read them. And at the same time, I'd like to request you that the most important part of a webinar is to clear your doubts. And for that, you can put all your questions in the Q&A box. Keep them straight on the point so that we can cover all your questions. any questions that you have with regards to your confusions on joining dentistry post the COVID era, you can put all your questions in the Q&A box. We will be taking the question and answer shortly. Once again, on behalf of Team DentistChannel.Online, I'd like to thank you for attending this presentation. I'm sure the session, like I've mentioned, was a fun learning session. Please do post your questions in the Q&A box. DentistChannel.Online, ladies and gentlemen, as most of you all know, is a dental media company catering exclusively to the dental fraternity. And all that I want from you is to stay in touch with us. And you can stay in touch with us by following us on our social media profiles, by subscribing to our YouTube channel, to our Facebook channel, to our Instagram channel, and to all our other social media handles, so that you stay in touch with us, so that we'd be able to help you with regards to a lot of events, webinars, etc. that we've planned specially for you. So all that I request is for you to subscribe to DentistChannel.Online. And yes, ladies and gentlemen, it's a very special event that we've launched for all the implantologists that might be a budding or an experienced implantologist. It's called as the world's first virtual implant expo. Dentist Channel Online has exclusively organized this event for all you people who are interested to know more about implantology. It's a power-packed virtual expo that would be taking place in the month of August. And a very special reason that we've kept the expo is so that we can help one needy dentist who's really looking out for some kind of financial help or whatever they're looking out for. So that's the main agenda through the expo. And there are two things that I want from you. One is you can register for the expo for free of cost. You can benefit from an array of masterclass sessions, scientific presentations that we've specially planned for you. And also, ladies and gentlemen, if you genuinely know a dentist who's in need of a financial help, and if we, DentistChannel.Online, can help him or her, please do get in touch with us. And we've promised, and the entire management of Dentist Channel Online has promised and rather pledged that we'd be giving 100% of the profit to that particular needy dentist or dentists. So if you know any person, please do get in touch with us, and please do let us know what kind of support he needs. You can register for the expo by logging on to www.dentistchannel.online/implantexpo. I repeat, www.dentistchannel.online/implantexpo. Like I already mentioned, it's a free of cost expo, and you can benefit from an array of masterclass sessions and scientific presentations. An e-certificate of participation for attending this webinar would be given to our Prime members of DentistChannel.Online. If you are not a Prime member yet, you can message us on the below mentioned WhatsApp number and you can become a Prime member. For the ones who are already Prime members, you can WhatsApp your full name and the name of the webinar on the below mentioned WhatsApp number. I repeat, an e-certificate of participation would be only given to our Prime members. If you're not already a Prime member, become a Prime member. And if you are a Prime member already, I request you to message us on the below mentioned WhatsApp number with your full name and the name of the webinar. And for the next webinar, we request you to kindly stay in touch, and you can log on to www.dentistchannel.online. You can look up to the next webinar. And now it's time for us for the question and answer session. If you have any questions, please feel free to post them in the Q&A box. Are we ready to start with the question and answer session, sir? Dr. Vinoo? Starting with the first question. Question from Dr. Rupanjan Roy. As by the chart,
Yes.
from D0 to D7 is asymptomatic, but still infective, whereas ICMR or World Health Organization says there is hardly any chance of transmission from asymptomatic cases. Sir, what is your opinion in this regard?
That's a very good question you should put forward. Actually, that sentence by the WHO, the doctor, I forgot her name, she's the one who put forward last week that there is no evidence for spread of infection when they are asymptomatic. But she had retracted that statement the other day, if you are aware of, and there was a high furor against her from the about it is that particular observation, and she retracted her statement unilaterally. So we still don't know, and we still feel from asymptomatic state, it is still infectious. We still don't know.
Thank you, sir. We move to the next question. Question from Dr. Samir Malik. So what is your advice on the use of anti-retraction handpieces?
I didn't mention that specifically because in this part of the world, we are using only anti-retraction handpieces. We are not allowed to use the other ones. That is a very important point. Actually, there are, in countries like India, we have usage of the normal handpieces which doesn't have the anti-retraction bar. That is very important because that will contaminate the water system, the water system, and that is not at all advisable. So we have to use anti-retraction, what you call the handpieces. Sorry, I didn't mention that because we are used to, that kind of handpieces.
Thank you, sir. Next question, Dr. Nishi. Are reusable surgical gowns advisable?
I am personally doing it because there is no way we can, change or throw every patient after every patient isolation gown. I am changing after every patient, but I am autoclaving my isolation gowns because otherwise it becomes, the PPE cost will skyrocket. So there is absolutely no problem in it unless and until it is, again, I saw one question that is coming in. The most important thing is minimum of 45 GSM thickness should be there, and there should be a impermeable, there is water filtration, water penetration shouldn't be there. So that kind of a gown, isolation gown, can be actually reused by autoclaving.
Thank you, sir. Next question from Dr. Monica. So since we are using quite expensive material, is it wise to cost more for the treatment? But already people are suffering from economic crisis. How should we solve this?
That's what I said. I know there are challenges. As I told you, it's not going to be cheap, but at the same time, it is not that bad either. If you look at the PPE I advised, I told you the isolation gowns can be reused, and also the shield is not very, very expensive. I think we are getting it around 15 to 25 dirhams in between those kind of shields, what I'm using. It's not, that will cost you around 500 rupees in India. It's not a big expense. That is a maximum, I said, maybe. And also about the respirators, which are actually a reusable one. And this is the one I always mention. Many people are saying, I cannot work with N95 and it is too expensive. And that is the reason why they are going into surgical mask. You don't have to. There is a very economical, comfortable solution out there. And CDC has already approved it. And that is an elastomeric filtration-based respirators. And these respirators cost here somewhere around 200 dirhams, which is in India maybe around 4,000 rupees. And you can contact your 3M dealer and you can get this mask. And there are filters can be attached to it. And some of the filters are very long lasting because, as I said, these filters are actually meant for not medical use. It is for industrial use. So we are not in any industrial kind of environment. So all these filters will last much longer than it is actually supposed to be. These HEPA filters or HE filters, which I showed you, that 7093 kind of, it is supposed to last minimum 6 months. So these masks can be wiped with alcohol swabs, or you can remove the filters and you can even wash in soft solution. So absolutely no problem to reuse it for a long period of time, and 3M masks are very, very durable. And since it has an exhalation valve, it is very comfortable to wear. It's not like an N95 mask. Every day I am using it in my practice and I don't find any difficulty in working with it. And it is very easy to fit check because it has a silicone border on it and the strings can be tightened well. So the fit check is very easy to do. You just need to press on those filters on either side and take a breath inside to see whether the silicone is collapsing or not. You will easily can do a fit check, and the 3M can certify and do a fit check for you if you want. That is also possible. So these masks and the filters together cost here only 200 dirhams. And I don't understand where exactly is the cost part we are talking about. These are reusable. So to me, I feel that of course, if you have been asked to do negative pressure rooms and HEPA filtration and AIR rooms, yes, I can understand it's not possible. That can cost huge amount of money and infrastructure. But what we are asking is, what we can adapt is quite very simple measures to go through this. Yes, the main problem will be for volume practices. That I understand. There lies the biggest economic problem, because in many parts of the world, They used to practice from going from room to room, even in United States, mind you, not only in India. Indian clinics might think it's only in India. No, no, I've been to different parts of the world. Even in States, they work from room to room, like open practices. And even in, I have to tell one thing in this about medical college, dental colleges in India. We have dental chairs all throughout lined up in one big hall. So in that kind of situations, we are seeing patients one after the other. The social distancing and all those kinds of things are quite difficult in that kind of situations. We have to look into it quite, that is the most difficult part I feel. That's seeing more number of patients. Yes, that is the economic killer rather than the PPE. I hope
Thank you. Thank you, sir. Beautifully answered. And I'm sure with that answer, most of the other questions have also been covered. Thank you so much. That was indeed a very clear, beautiful, crisp and clear answer. We move to the next question. Question from Dr. Gaurav. Which fogger do you recommend? Please specify.
Actually, to be frank, the fogger is a machine which atomizes this liquid. There is many available. In India also you can get one. And here we get only these Chinese models. There is a Japanese model, which was very expensive. What I showed you is a Chinese model, to be frank. And I have it's the one I procured in the beginning. To be frank, we use it only by the end of the days. And sometimes if you do a lot of aerosol generating procedure and we want to shut the room down for a long period of time, then only we use it. And the solution, that is the most important thing. The solution, as I said, initially we started using sodium hypochlorite, but later on we found that is not very good. So we moved away from that and we are now using mainly either hydrogen peroxide or any kind of alcohol, which is more than 70%, like isopropyl alcohol. So the main purpose of a fogger, as I told you, it hits on the aerosol and it makes it dense and heavy and it falls down. Mainly the problem with the aerosol is it is so light that it floats in the air in the room. That is the problem. We cannot catch them. It floats in the air and it can come through the air and inhale. So that is the risk there. So if you can bring it down, you can, as I told you, there are 3 ways. You can open the window, it will fly away because that is the most tiniest part. Any air movement comes, it will be the first one to go out. Then next will be an HEPA filter, which can, filter them out. Third option is fogging to make it dense and fall down, then wipe. All these things are different options. Any of these you can choose. I hope I answered your question.
Thank you, sir. Next question from Dr. Jasleen Arora. It was a great session, so thank you so much for the lovely presentation. What precautions or guidelines we need to follow for any implant procedures or fixed prosthesis?
Look, I am an implantologist and I would say there is no extra precautions that you need other than your normal surgical setup. Only thing what you need is your extra PPE. And normally for surgery, actually, to be frank, it has less aerosol compared to any other normal dental procedures. So I don't think there is anything extra required other than the surgical PPE you do, plus a good respirator and a face shield is good. There is nothing else you need to do specifically for implant surgeries. Absolutely no requirement.
Thank you, sir. Next question from Dr. Neha Kumari. What kind of advanced suction techniques we can use other than applying rubber dam?
As I said, what they say is that if you are doing your procedure, your practice is using rubber dam or isolation systems routinely, then a high vacuum suction, the one which I told you, the forward one, whichever the criteria fulfilling one, will be sufficient, or it will be sufficient. While if you don't have that and you are not doing all those things, you can look into an extraoral suction. This is an option. Okay, there are many kinds of extraoral suctions available, but most of the thing what you need to know is it should have a HEPA 13 filtration or a UV filtration, because otherwise that will be another problem that you'll encounter in your room. So what other suction systems? You can go to the extent of a negative pressure room where you have a different pressure gradient to suck out the air from the room and have a HEPA filtration in the HVAC system itself. So these are all very high engineering, costly procedures. You don't need to get into it. What you need to do is, depending on your practice, adapt your own best possible defenses. That is, you can use, if you are using rubber dam, a high vacuum suction is more than enough. But if you are routinely not using rubber dam, then an extraoral suction may be an option. If not, put an HEPA filter. Any of those things you can incorporate to reduce the aerosol generation. That's what they said. I said before, it is a layered way of doing it. You cannot do it by one. You are trying to minimize the aerosol by incorporating different methods. So one or two here and there you don't have, you can compensate it with something, with another one. So there is no requirement for anything other than that for any suction.
Thank you, sir. Next question from Dr. Arjita Sood. Sir, can you share the model name of Blue Air HEPA filter with its HEPA 13 grade? If possible, the approximate cost.
Blue Air is from Sweden and IQ Air is from Switzerland. And surgical cleaner is from Canada. I don't know the availability of all these things in India or any part of the world. Here we don't, we have the IQ Air and Blue Air, but Blue Air is out of stock. IQ Air, I think they are bringing in the new shipment by the next week or something. That's what I last heard of. Blue Air, one thing you should know that if you're going for a HEPA portable unit, apart from the medical air changing, you need to have a monitor to monitor the air quality in the room. So there are models for Blue Air which comes with that. Okay, there is something called as classic model, classic 280, 480i, it is called. I is with the monitor. So now the point here is which model you need. It depends on the size of your room. As I told you, you have to do the maths for it. If the size of your room and the capacity of your HEPA filter will give you the CFM value, that is the air change value that you need. Sometimes the air change value for is 280 model maybe for the 200 square feet room, and a 480 model is for a 400 square feet room. So if you put a 480 model into a 150 square, the 150 square meter room, then what happens is that it will have more air change, and it will change maybe 3 or 4 times the air, because it is more powerful and it has more air change capability when it is put into a small room. So that calculation you have to see with your operating room, okay, and which model to buy. So there are different models, and that models will give you the exact square feet it is meant for, and also the air changing CFM and CADR, CADR. These are the values you need to know. If anybody wants to know details about it, you know how to calculate that, you can email me or WhatsApp me in those numbers. I can tell you about it. Hello, I think I have answered the question. Hello.
Thank you for answering to the question, sir. Move to the next question. Question from Dr. Sara Abbas. How effective are UV light disinfections compared to chemical disinfections?
Oh, at the moment, we don't have evidence for UV light, to be frank. They are coming up with some studies, but at the moment, the most reliable tool is your chemical disinfection. That is wipe, wipe, and wipe. That is the best thing. And you should have minimum 70% alcohol in whatever disinfectant solution you're using. And there are a lot of combinations. And recently, I found a study by Gordon Christensen, which he did a study on all the commercially available disinfectant solutions for dental clinics. And he found only 2 of them, which are good enough to kill these, or this is what you call seedability of them in 3 minutes. That is only 1 or 2 models from Canada. It's not available here. And what we had here was Cavicide, which actually found very low in the rating for a 3-minute study. You know, it is to kill in 3 minutes. See, the point here is after each patient, you wipe, but we don't know whether that wipe alcohol has already killed the virus. It needs time. So sometimes some alcohol solutions needs almost 10 minutes, 15 minutes to kill. While the study was on how fast it can be done, and he found only 2, I think Biosurf was one Canadian company, which has done it in 3 minutes. So basically you need to do your study about it, which one is better for you. And main thing is chemical disinfection, wipe, wipe, and wipe. That is the most important thing.
Thank you, sir. Last two more questions. Question from Dr. Arjita. How many liters of water should a high vacuum suction suck in 1 minute to qualify?
That's what I said. What we found was 1 liter in a bottle. If you start your suction, it should completely suck that water out in 50 seconds.
Thank you, sir. Last question. Question from Dr. Rita. Can we use a cloth surgical gown as it is economical?
Cloth surgical gown? Yes, of course. We can use that, provided, as I told you, the cloth, one of the problem is it is not water impermeable. You know, it is the normal clothes, the water comes on the other side. You need to have a gown. There is no impermeable water resistant ones. That is the problem with the normal clothes. While GSM level 45 onwards, any isolation gown has that.
Thank you, sir. Well, that brings us to the end of the live question and answer session. Once again, on behalf of Team DentistChannel.Online, I'd like to thank each and every participant for being so patient and for joining us for this live webinar. I am sure you all would want to watch the webinar once again because it was such a beautiful webinar packed with so much of information before you start with your clinical practice. If you wish to watch the live webinar again, you can watch the recorded session by tomorrow morning on our YouTube page, that is DentistChannel.Online. Thank you once again for attending this session.
Can I conclude something?
Please, sir.
Yeah. So I want to conclude this by saying that don't succumb to the fear psychosis. Please open up your practices. But as doctors and dentists, be responsible about it and try to adapt maximum protection to make yourself safe and your family and your patients and your staff. And also give an impression to the patients that we do have good protection because they are also scared. So we all need each other to get through this. And there is no point in denying the enemy, also no point in being scared about it. We have to take it head on, but head on, you take it with proper armamentarium and weapons. Thank you.
Thank you, sir. I'd like to thank you specially for the beautiful webinar, for your lovely time, and for so much of information that you've shared with our participants. I'm sure each and every one is all set, geared up to begin with their dental practice. Ladies and gentlemen, as it's already mentioned, I also request you to kindly stay safe and be responsible. Thank you very much, Dr. Vinoo. It was a lovely presentation. With this, we come to an end. May you all have a good evening.
Thank you.